Welcome to Hatherley Behavioral Health's Clinical Conversations. Today we are speaking with psychologist and author Nicoletta Skoufalos, author of Understanding Autoimmune Disease, A Therapist's Guide to Invisible Illness. Before we get started, just a reminder, if everybody could mute themselves. If you have a question, feel free to put it in the chat. We'll be monitoring that throughout the conversation. Or at the end, if you'd like to raise your Zoom hand, we will call on you and answer your question that way. So Nicoletta, again, thank you so much for being here. I know I'm very eager and excited to learn more about autoimmune disease and how, as clinicians, we can best serve our clients. So if you'd like to introduce yourself, tell us a little bit about your background and also what was your inspiration for writing this great book?
Thank you so much, Kortney, for having me. I'm so glad to be here today. Um, so I'm a clinical psychologist in New York City. I've been in private practice since 2011. And I've been working with the autoimmune disease population for the entirety of my career, essentially. The inspiration for this book came partly from my own personal experience, as well as working with a lot of clients who have autoimmune disease. And it's been a long time in the making. It's a book I have wanted to write for a very long time. Um, and I'll tell you a little bit about my journey and how that got started. So, when I was in my last year of graduate school, um, I was working on medical floors in one of the hospitals in New York City, working with patients who had all sorts of medical diagnoses. And I myself started to have some really intense physical symptoms. I developed swollen joints, pain in my joints, rashes, and I was also completing my dissertation. So I was very stressed. And I did to myself what I learned commonly happens to people who have autoimmune diseases. I didn't know I had an autoimmune disease. I thought I was just stressed and that this was a psychosomatic um, reaction that I had to process in therapy and that I would be fine. And I was very fortunate that I had a wonderful supervisor who said, this looks like lupus. This does not, I don't think this is just stress. Um, and it ended up being lupus. And subsequently, I was also diagnosed with rheumatoid arthritis and early Sjogren's syndrome. Um, so that was my foray into autoimmune diseases. And I have to say, when I went to the doctor and they ran the blood work, I was very lucky because I was diagnosed quickly as well, which is very uncommon for autoimmune diseases. And I was told, you have lupus. I had no idea what lupus was. I'd never heard of it. And I quickly learned that many people in the mental health field have no idea what autoimmune diseases are. Now, a lot more than this was 2010 when I was diagnosed, but still, they might know a little bit that it's a common form of diseases, but not really know what the experience is like for people living with autoimmune diseases. So I wanted to write the book for two different populations, really. Um, Primarily, it's for mental health professionals who want to learn to work with this population. But ultimately, it's really for the clients who oftentimes seek out help in therapy and end up feeling worse rather than better if they go to someone who has no idea how to work with this particular type of experience, which is quite unique, I think.
Hmm. I agree. So for behavioral health clinicians that don't have a lot of background with autoimmune disease, how would you define it for them?
Sure. So very generally, autoimmune diseases are a body of diseases in which one's immune system can't differentiate between foreign invaders like viruses or bacteria, can't differentiate that from one's own body. So your own immune system might attack your brain, your tissue, your nervous system, really any organ of the body, skin, respiratory system. Um, And when that happens, it creates inflammation, and that inflammation is what sets off the symptoms that the person might experience. Um, Apologies, there's a fire truck right outside. I hope you can still hear me.
Weekend. You're in New York City, right?
New York City, yep.
Yeah,
Major intersection right here.
that's all right.
So it sets off the symptoms, and there are so many different autoimmune diseases, but some of the more common ones are multiple sclerosis, lupus, type 1 diabetes, rheumatoid arthritis, still disease, celiacs, ulcerative colitis, Crohn's. These are the ones that I think people hear most about. And there is a genetic predisposition, um, but not everyone with that genetic predisposition will get an autoimmune disease. Something in the environment has to trigger that, the genes to turn on. And it's not necessarily one gene, it's like a body of genes, and different for each autoimmune disease. And the environmental trigger could be viruses. It could be like Epstein-Barr virus, very commonly, chronic stress, toxin in the environment. It's not, there isn't a rhyme and reason necessarily to what triggers it.
Well, I think the title of the book too, How the Invisible Illness, I think really describes it very well because like you said, it goes a lot unnoticed. And why
Mhm.
do you think it does that, even with, the medical profession and the behavioral health community?
Yeah, I mean, there's many layers of the invisibility, right? In terms of the medical profession and thinking about also funding and research, more than 85% of people who have autoimmune disease are women. Um, and sadly, women's issues are often underfunded. Um, Additionally, it's often invisible in the sense of the symptoms are not always visible, right? Someone might have pain in their joints, but they might look well, they don't look like there's someone who would stereotypically be labeled as sick. Um, Women are, it's very well documented that women are not taken seriously when they report pain. So oftentimes they're told, this is all in your head, you need to go to therapy, work it out, it's unprocessed trauma, and they're not getting the proper medical attention that they need. Additionally, in particular autoimmune diseases like lupus, for example, it's not only primarily women, it's primarily women of color. So oftentimes some of these women will be told they're seeking pain medication, and then they're not getting the treatment that they need. It's really interesting, actually. If you look before COVID at NIH spending in terms of how much was spent on research for autoimmune diseases, it was very little, even though like lupus, for example, is one of the leading killers in women, right? The the funding was significantly less than other diseases like cancer, breast cancer, for example. After COVID, with the onset of like long COVID, a lot of men develop symptoms that are very similar to autoimmune disease like symptoms, and there might be a relationship between long COVID and autoimmune disease. The funding doubled. So if you look at the 3-year period post-COVID versus the 3-year period pre-COVID in terms of spending, it doubled. So that says something about, why this is an invisible body of illnesses. It's primarily gendered.
Mm, interesting and sad at the same time.
Very sad.
But
Yes.
nice that now it's getting a little bit more, recognition and in the research that's needed.
Yes.
And you bring up an interesting point where a lot of times you said there has to be, there's a genetic predisposition, but then an environmental kind of trigger. And I think that's probably what a lot of us see. We have a client that comes to us for, stress or those environmental triggers. And if we don't collect, certain information and intake or have a good, background history, even, with the therapist lens, we're thinking, oh, okay, it's stress, it's environmental, it's situational. And sometimes we don't even think, okay, what else could be going on medically? So and if you have a case study, that's great too, but what would be the best practices for having even initial intake appointments now that we have, a little more background of autoimmune? And are there specific, I guess, questions to ask the clients when they come in?
Yeah, so we do know that autoimmune diseases run in families. So it would be, and generally it's good practice to ask about medical history, right? And medical history in family as well. So that's something I always want to ask about. You want to ask about any sort of physical symptoms the person might be having. Um, if the person is fatigued very often, you want to ask questions to differentiate, is this major depression or is this fatigue occurring in the context of certain other somatic symptoms as well? Something that's really interesting that happens sometimes is a person might actually be depressed, but then their depression is successfully treated and that fatigue still lingers, right? But there's no other symptoms of depression. Like, that's a curious thing. So you would want to ask about, do you ever get rashes? Do you often find yourself going to the doctor and being told there's nothing wrong with you? Do you ever have joint pain, joint swelling? Do you ever have gastrointestinal issues? And again, a lot of these symptoms might overlap with depression, but you want to rule out like the other classic depression symptoms, right? Like sleeping issues or hopelessness or suicidality. And sometimes you can't always tease these things apart because they both might be occurring at the same time. But I think it's good to ask some of those questions to try and see, like, are these somatic symptoms occurring separate from any mood issue?
Okay. And in your experience, have you seen, or kind of what relationship have you seen between autoimmune diseases and, anxiety, depression, bipolar? What's that relationship like with the different disorders?
Sure. I think the three primary mental health issues you see in autoimmune disease are depression, anxiety, and trauma. Um, with depression, so they all kind of have a different relationship with the autoimmune disease. So depression and anxiety both occur in a lot higher rates with autoimmune disease clients than they do in like the general population. For depression, it's mostly the result of dealing with the stressors that come with living with an autoimmune disease, right? Like, it's not fun to live in pain. It's not fun to have doctor's appointments and tests all the time, or to lose maybe a relationship because of the struggle you're going through with your health. Um, so, coping with the illness can contribute to depression. Sometimes body image issues can contribute to depression because autoimmune disease patients often take high doses of steroids, and that can lead to weight gain or swelling of the face. Colloquially, it's called moon face, which is not a very nice thing to say, but it changes how you look. Some patients are depressed because they can't go into the sun anymore because the sun can trigger a flare. So there's also decreased vitamin D at times, and also just sadness from not being able to go in the sun. That happened to me. I have, lupus, and it's triggered by the sunlight. I love the beach. I have to wear a hat. I look like a beekeeper, a giant hat, long sleeves, long pants. Um, and it's very sad. I felt like I lost a part of myself. You can also, experience depression because you feel like you lose parts of your identity. You might lose your job. You might lose certain friendships. And then also, the autoimmune disease itself can cause depression. Because of the inflammation, there's recent studies that show that that inflammation could result in depression. That's different from anxiety. So with anxiety, um, oftentimes it is the result of the same stressors that cause depression, but the high doses of steroids can also cause anxiety. It can make you very jittery to be on high doses of steroids for a long-term period. but there isn't a direct relationship, unlike depression, between the actual disease and anxiety itself. The inflammation doesn't cause anxiety. Um, with trauma, so trauma is the most complicated relationship with autoimmune disease because there is some evidence showing that people who have PTSD are at higher risk of developing an autoimmune disease. There's no evidence that says depression and anxiety puts someone at a higher risk of developing autoimmune disease. That doesn't mean that everyone with PTSD will develop an autoimmune disease, and it doesn't mean that everyone with an autoimmune disease has PTSD, but there is some relationship there. And there was a very large scale study looking at veterans, and the veterans who had PTSD, they had more than 53% higher chance of having an autoimmune disease, even if they weren't in combat. It was just that diagnosis itself, which was really interesting. But separate from the predisposition that PTSD puts you in, living with the autoimmune disease creates a lot of trauma in itself as well. So getting that diagnosis for some people could be experienced as trauma. Going to multiple doctors and being told repeatedly, like, there's nothing wrong with you, because it takes an average of 7 years to have a diagnosis. So there's another study that shows that even 7 years later, after receiving the proper diagnosis, people still experience trauma symptoms from being repeatedly told, it's all in your head, you're fine, exercise more, go to therapy, you'll be fine. So there's the trauma of that. There's the trauma of what I call the what may come. I write about that in the book, this feeling of not knowing necessarily what's going to happen to your body next. Because with autoimmune diseases, the symptoms, course, and prognosis vary so widely from one person to another that, and no doctor can really tell you, like, you might be fine for several years. Maybe your only symptom is a rash. Or you could have kidney disease and end up in the hospital and need a kidney transplant. Or you could die. And there's no real way to know what your particular course is going to be. So there's a lot of sitting with that terror of the unknown. There's also the trauma of, like, I have a really bad flare and now I'm better, but I don't know when that bad flare is going to come again. So the what may come is another source of trauma. So there's just these constant layers. And then there's just a lot of microaggressions against people with disabilities who don't look like they're disabled. So oftentimes, you might need an accommodation, and you might be made to feel like a terrible human being for asking for accommodation, and that person thinks you're just trying to get out of something. So those are the main ones. And then there's also brain fog, which is another mental health issue that overlaps a little bit with depression as well. But I think I'll pause there for now. Could talk about that.
It shows like a very dynamic and multi-layered, disease, and how we best treat it, I think can make a huge difference in that client's life. And I think the more we know, obviously the better. And it sounds like a more holistic approach where we're talking to their doctors, if the client is okay with that, and really getting the big picture can help more. I have a client too with an autoimmune disease, and she kept saying, with friends, I'm losing a lot of friends because, I say I want to go out, and then the day comes and I don't feel like going out, and then they get upset. And it's hard. And she's younger, she's only like 19. So it's hard to manage a lot of those different areas of your life when you're dealing with this. So I guess as if someone comes to us, what's the process we can expect, like kind of what our treatment plan look like for them in dealing with, the trauma of it, the grieving of, not having the life that you thought you would have, And then
Yes.
also the day-to-day functions that can be tough. And I know Nicoletta and I spoke earlier about how, I'm a big proponent of positive psychology, and solution focused and not that it's you always have to be happy, but thinking about the optimistic view of things.
Yes.
I liked in your book that, you can't just jump to that, especially with an autoimmune disease. And how do we best help our clients sit with that uncomfortable feeling and that grief of my life isn't what it used to be?
Yeah.
And how do we validate how they're feeling, but also motivate them, I guess. I don't even know if that's the right word, motivate them to do things differently, I guess. I don't want to say better, but how do we get them to live, I guess, the life that they want to live?
Yes. It's I like the word advocate, right? Like it's helping them to get to a place where they can advocate for themselves and live and adapt, right? Live a more adaptive life based on having to manage their disease. You're right. You can't just jump to that part though, right? Like you want to get there, but these are people who all the time are misunderstood and not believed. And you don't want to come in and be another person who's going to tell them what to do when people keep telling them what to do and missing the boat. They want to be heard, and they're dealing with a lot of grief and loss. And nobody might even be picking up on that, right? How much grief and loss there is. Such subtle things like even like the sun example, right? Like that's such a who really thinks about that? But that's a big loss for some people. Or the losses of having a carefree dinner with friends without having to put on an insulin monitor, for example. Um, so I think where you start is you listen. You don't jump in asking them about trauma because I think we have a tendency, at least I come from the psychodynamic world. So at least in from that orientation, we think a lot about developmental trauma. And there is this relationship between PTSD and autoimmune disease. So it is easy to kind of want to address that right away. But I always say that's a surefire way to shut the person down. So just start with tell me about your experience, right? Like I want to learn. They're the expert on what's going on for them. And you need to be there for them to help them process their grief and help them identify the loss. Additionally, oftentimes because of the relationship to trauma, there's a lot of dissociation and alexithymia. So a lot of these clients might not always have the words to identify their feelings. And also there's brain fog, which causes problems with word finding and concentration. So this is a slow process of making space to listen, helping them to find the words to process their grief, and just staying with them for a while with that. And then there will be shifts that you will notice. Um, Sometimes I hear phrases like, I'm so sick of talking about this. Like, I'm done. Like, I don't want to talk about this anymore. That's like your little signal there that, like, great, let's think about how you can do it differently, right? Like, I know you feel lost here. Um, that part of you doesn't, you feel like that part of you doesn't exist anymore. But maybe there's another way to express that part of you. You used to be a runner, and I know like you feel like you've lost that. But does that mean you can't go for long walks anymore and still connect to what made running special to you? Was it the nature, your connection to nature? Was it the peacefulness? Help the person find the aspects that make that person feel happy, that can still exist even though something functional was lost. But you have to hear those little signs of like, I'm sick of talking about this. And you have to help them get to that point of being sick of talking about it, right? Then they've gotten to a place where they've processed their grief.
Okay. We do have a question. Can allergies be a cause from issues with immune system? Do you feel a specific diet would be helpful to the client?
So there is some research that shows there's some relationship between some allergies and autoimmune disease because they both cause inflammation. Um, but that's the extent of my knowledge in that area. In terms of diet, I don't think there's anything empirically validated. Um, I believe actually for Hashimoto's, there is some research that says gluten-free diet is helpful. And there are a lot of doctors who work with integrative nutritionists to do certain elimination diets that can be anti-inflammatory. So they do a blood test and then they tell you for your particular results, it's very individualized, which foods could cause inflammation. And then they work with you to eliminate some of these foods temporarily. And then you slowly work them back into your diet. Some people find it very helpful, even though there isn't solid research yet, but anecdotally, people find it very helpful. But it's very time consuming and you have to be super disciplined about it.
Um, have you found too when clients come to you, are they, we always want to feel more in control. And a lot of times with an autoimmune disease, we don't have a lot of control over things. So I really like how you were saying, you change, eventually your mindset of things. So like with the running example. Um, two questions. One is, and there's probably not a specific answer for everybody, but that period of like the grieving period or the, being angry period almost. Is there I know with grief there's not, but is there almost like an appropriate amount or the best clinical amount of time for a client to stay in that feeling before we go to, is there something else you could do that gives you that same feeling?
Yeah, I think that's a really difficult question to answer because it'll depend on the particular person's circumstances, right? Like someone's loss might be, they lost a relationship versus else's loss might have been like, I lost a limb. Um, and the length of time might look very different for those two people. I think it's less about time and more about the function of the grieving. So, like, if someone might be grieving for a long time and it feels healthy and appropriate, that they're like actually processing the feelings and you feel that movement in the therapy, maybe it's okay that it's taking a long time versus if it's someone who it's not serving them anymore and they're just kind of stuck in a dark place and then it just feels like a hopelessness and that maybe they're kind of repeating the out of controlness that the disease already makes them feel, then maybe it's worth saying something about that and commenting on it. But I think it's more about the function than the time.
How do you feel like the feeling in control and giving clients really kind of specific, tangible strategies and things to do helps with, like when you were mentioning like the diet and the elimination diet, it feels like something they can control. How does that factor into their treatment plan? And in your experience, does it make them feel, like I said, more in control or better about things and a little less anxious? Or is it for them one more thing, that they have to do?
It's a complicated relationship. I think it's really important that patients do these things. Like exercise is really important. I always work it into the treatment plan because it also helps reduce inflammation as well. And we know it helps with anxiety and stabilizes mood. So it's really important to exercise. It does help people to feel more in control because it's like, this is something I can do to help myself, right? To feel better. Where it gets tricky is sometimes it doesn't work. And then that could leave the person feeling very frustrated. Like, I've done everything, right? I've done the elimination diet, I've done the exercise, and yet I still feel sick. Um, so that's what's really hard with autoimmune diseases. Like, there really isn't a, a lot of control in general, and there's no cure. So it works for some people, it doesn't work for others. And that grief we were just talking about, like I call the chapter like loss and repeat, right? Because it's a constant loss, it's a constant grieving. The exercise might make me feel better for a while, and then it stops, and then I grieve like the temporary health that I was feeling in that moment. But it's still important to work it into the treatment, right? It's still important to help people feel some sense of agency. And there's other ways to do that too, like not just with trying to make yourself feel better physically, but to like create meaning, right? I always say advocacy is a really, really big deal. Um, Try to get involved with organizations or foundations, try to spread the word, educate people on what these diseases are. And that can look, can take any form that works for that particular person, but it makes you feel like you're making some meaning out of the illness. And that can help you feel a little more in control as well.
I think when you're talking about grief too, I think you can grieve things. I'm sure it changes depending on like the phase of your life too. So maybe,
Right.
and I'm not sure, do you know when do most people get diagnosed? Do you have an age?
It depends on the particular autoimmune disease. So, like for example, lupus gets diagnosed childbearing ages, usually between 20s and 40s. Rheumatoid arthritis is a little older in the 40s. So it kind of depends. Um, Guillain-Barré is like in the 50s. So it varies.
Hi. So
Yeah.
right, it could be difficult depending on what you're doing in that, part of your life. And I would assume treatment would look different for people, depending on their ages and,
Yes.
life path. Um, how do you suggest we kind of build that resilience in our clients when we know that there's no cure and that every day is different and that you don't have a lot of agency? Have you, and in being someone who, is diagnosed with an autoimmune disease too, I think, gives a invaluable, expertise with it. Are there certain things that even you found helpful as a clinician and an individual to help kind of build that resilience and that energy and positivity to kind of keep, moving forward and still enjoying your life?
Community is a really big one. That's something I always like to talk to my clients about. And you need to feel like you're in a group, and it doesn't have to be a community of people with autoimmune diseases, although I think it is very helpful to join some community of people who know what you're going through. But there's this constant feeling of, I don't belong in some way because people don't get this. So feeling like there is some group in which you belong kind of gives you a little bit of that momentum to keep going. And with that, too, like when you're feeling not great, that community can help you think about different ways to make meaning. And that's something I will work on with them in sessions too. Like for me, for example, I learned how to, I started writing because of that. And that kept me going. And when I felt at my worst, that's when I started writing I started with blog posts. I would write these blog posts. And people would send me emails from other places in the world and be like, oh, I totally feel that. Like, thank you for sharing. I have a similar experience. And they felt helped. I felt helped. And then I said, okay, I keep going because of that. So that was my version. Everyone has their version of that, but you need people, some sort of connection. I think that's very helpful. Um, and in terms of building resilience, also, I think it's important to help clients to advocate for themselves, like to be able to say what their needs are very clearly, because there's a lot of shame sometimes in asking for what you need. It is helpful to help them work through some of that shame. So when you ask for what you need, then that's also helpful in making sure you can keep moving forward. Otherwise, you might not get what you need and you might not be able to do your job. You might not feel satisfied in your relationship. You might not get the right medication. You might be stuck with a medication or with a medical provider who isn't helping you to move forward during that hard time.
Right. Again, it's about the connection, community, finding that purpose. How
Yes.
does family therapy and family work play into a client with an autoimmune disease?
Yeah, personally, I don't do family therapy, but it could be very helpful because oftentimes that's one of the complaints that clients have, that my family doesn't understand. They think I'm lazy. I think this is the thing, right? We make a lot of assumptions about things that we don't understand or that are unknowns and we don't have answers for. So the family sometimes might feel helpless and might not know what to do. And so they might think they're being helpful by pushing the client. You can do it, just a little more, stop being so lazy, or why did you go out in the sun? You shouldn't have done that. It's kind of like blaming the patient. Why are you eating unhealthy food? You should eat better, instead of knowing how to listen, be understanding when they need to cancel last minute or are feeling tired, not understanding that what feeling tired means for a person with autoimmune disease isn't just regular feeling tired, it's like complete depletion. Um, it could be helpful just in terms of education to have the family involved in some way. And I always tell like clients, tell their families to attend like educational events through different foundations. Like there's so many, and through hospitals as well.
Mhm.
It's very helpful.
I was going to ask, and we can put it in the chat later if you have things kind of off the top of your head, but are there specific like resources that you would suggest for people, even if you're just newly diagnosed, like how to advocate, like the healthcare system, anything that would be helpful that we could give our clients or send them in the right direction?
Yeah. So like in terms of lupus, the Lupus Foundation has a ton of resources, educational resources. The MS Foundation also has resources. Most of these diseases have their own foundation and have educational series all the time. And they also have support groups that meet in like the local chapter of whatever area, right, in a hospital of that area. So that's a good resource. Like HSS in New York City on their like rheumatology department page has some articles and resources as well.
Okay. And I know you have a continuing ed course about it that, behavioral health clinicians can take. But I guess a question is, and it's a yes or no question, I guess, but if I have a client with autoimmune disease and I am not an expert in that, should I refer them out? Do you think it's appropriate to learn together? I mean, what's in the client's best interest at that point?
I think you need to educate yourself. You don't necessarily have to refer them out, but you must educate yourself because you could do more harm than. Um, so I would say, yeah, like read whatever you can, consult with someone who does have experience with that, take a course, that kind of thing.
As far as medication goes too, are there specific like psychological symptoms, like the side effects of the medication for autoimmunes that we should be on the lookout?
So in terms of psychological, if you're on high doses of steroids for a long term, it could make you very anxious and jittery. That's the primary one. Not so much the other immunosuppressants. They have other side effects, but not so much psychological ones.
And we have one question I missed. Do you know how can you explain that there are more autoimmune diseases in the US than in other countries like France? I'm not sure if you have the answer,
Oh,
but
that's interesting. I don't have the answer. I know we have a much bigger population than France. I don't know if it's just a factor of that, or I don't really know the answer to that.
okay. Yeah, it's an interesting. Now, when we have clients come in, are there specific therapeutic approaches that you think we should take that you take, in supporting our clients with the autoimmune disease? Is it similar? Or are there specific kind of modalities that you think would be best for them?
So, in terms of the research, both CBT and psychodynamic therapy have been studied, and they've both been found to be very helpful in terms of helping the person with adaptive coping and adjusting to the illness, as well as managing like the depression, the anxiety, and any trauma related to living with the autoimmune disease. So it doesn't really matter what the orientation is. They all seem to be helpful from that perspective. I think what's most important is just the listening stance and the number one, believing them when they tell you they have symptoms and they feel like something is wrong, making space for the grieving process, helping them with the reduction of shame, helping them to find the words for their feelings. So helping them to work through like if there's any dissociation or alexithymia, making meaning, and then that last piece of advocacy and kind of finding new ways to hold on to your identity despite the changes. But there's no particular orientation that is superior to another.
Is there anything that we should stay away from? Things that we should avoid?
Definitely, like I said, don't start with like this is trauma, so let's process your trauma. I would stay away from that in the beginning. The trauma will emerge and then you can work with it as it comes.
Have you seen, or I guess, what would the difference in treating be if someone came to us with the diagnosis of an autoimmune disease as, compared to somebody who we've been seeing for a while and then realize, okay, you have the diagnosis. Is one kind of different to treat than the other, or what's been your experience with that?
Um, it is a little different because, when you have a label, there's some sense, even though it's traumatic to be diagnosed with a chronic incurable illness, you have a sense of relief that there's like a label now, and like, okay, this is real. I didn't make this up. So that's a difference in the experience as well. And they might already be on medication. So that may be different. Something else that I didn't mention before that I think is important to mention, and that could come up when someone's been living with the diagnosis for a while, is sometimes people with autoimmune diseases might look like they have a personality disorder at times, and they might not have a personality disorder. In fact, they likely don't. That's not, it's not like depression and anxiety that's often comorbid with it. Because of your sense of security, and even if you have a secure attachment style, things can get shaken up a little bit because of the fear. And am I going to lose this person? Am I not going to lose this person? Can I trust that they'll be here for me or not? There's so much of that gets shaken up that they could look a little bit insecure in that way. So that's something that you might also see when someone's been living with an autoimmune disease for a while.
Interesting. All right, we have a question. One significant concern is that the patient is more vulnerable to many diseases due to the suppressed immune system. This is a realistic cause for anxiety. This should be considered as well.
Mm-hmm.
Any thoughts on that? I mean, it makes.
Yeah, totally true.
I think there's a lot to consider, and you really need that holistic, approach and collaborating with everybody and getting to know, the client, as a person and not just as a diagnosis too, and realizing how it affects every layer, an
Yes.
aspect of their life, and connecting them with support groups and just, other family members or things that bring them enjoyment. What do you wish more behavioral health professionals understood about autoimmune diseases?
Yeah, just how complicated they are and how many layers of a person's life they affect, and that these are not just examples of somatization, that these can be very serious and life-threatening illnesses that can devastate families. So just to take that seriously, I think that's the most important, the bottom line here,
Mhm.
to take it very seriously.
We're almost wrapping up. If there's any other questions, feel free to put them in the chat. And Nicoletta, if there's anything else that you would like to share with us, again, I thank you so much for being here. I know I learned a lot, and I think now we'll have a different lens when we're talking to people, and autoimmune diseases will be on my mind all the time now. So thank you.
Thank you. I want to share one last thing because I think it's very important. There is some new research right now. This is very new, that possibly some cases of schizophrenia are undiagnosed lupus of the brain. And there was a case recently in New York of a woman who, for years, was diagnosed as schizophrenic and serendipitously, because of some other medical condition, ended up on um, some chemo that's also used to treat lupus. And she was no longer presenting as schizophrenic. So there's just so many layers here. It's so complicated. So just keep an eye out for new research all the time, and everyone just keep educating yourselves on these illnesses.
Great. Thank you so much.
Thank you.
Nicoletta has a book out and a continuing education course. So if you want more information about autoimmune diseases, you can go to hatherleybehavioralhealth.com. Oh, we have one more question. As a medical provider, I'll always remind her to check and clear all medical health first. Yes, before signing up
Yes.
for mental health. I think that's very good advice. And I hope everybody can join us next month for our clinical conversation. Thanks again for everybody for being here.